Good morning, PTNI's Daily Show. How's it going? I am Dr. Lindsey Hughey from our Extremity Management Division, and I am coming to you live on a Clinical Tuesday. Today, I want to chat with you about the roller coaster of diagnosis and treatment with FAI. So I want to review a little bit about the history of femoral acetabular impingement, and then review the current kind of problem that exists in our management of that as a healthcare system as a whole, not just as PTs, and then propose a solution for us all, and specifically what can we do as a physical therapy profession to improve care for folks with FAI. So first things first, we'll go through the history of FAI because it's been kind of this up and down approach since it was discovered. So to take you back a little bit, in 2003, Gans et al. Published that FAI, when it's found on imaging, leads to osteoarthritis. So that was established. And then in addition, around that same time, 20 years ago plus, surgeons learned how to dislocate the hip in surgery without compromising the ligamentum teres. So then there was no risk for avascular necrosis. Actually, what they really found out was that, to get a little nerdy, that the medial femoral circumflex artery was the main contributor to femoral head perfusion, and that ligamentum teres and its associated vestigial artery had little, if any, role in the femoral head perfusion to the adult. So basically, they found that it was safe to dislocate the hip, and they were able to view bony anatomy much better. So this allowed more access to visualize problems associated with FAI. So they were more easily able to identify cam-type FAI, that offset of the femur, and at that neck junction, right, which causes, this is when they said this is what causes tears of the labrum and leads to OA. And then they were also easily able to see pincer, which is that over coverage of the femoral head. They find less of a link to that, to OA, but nonetheless, both were easily visualized. They even saw a big proponent of folks having mixed presentations of both the cam type and the pincer. So with this surgical technique, and then with this big finding that Gans et al. Published in 2003, a skyrocket of surgery started for FAI. And they thought they were doing a lot of good, surgeons, by doing surgery. As soon as they saw on X-ray and MRI, once they saw some type of cam or pincer lesion, they would go in and just do surgery, especially if it was cam, because they wanted to prevent the sequelae of OA. So while very well-intentioned, this crusade of the white knife ensued. And so what happened was, from 2003 to like 2013, there was this 5 times increase in surgeries for FAI. And then surgeons started kind of pausing a little bit and reflecting, is this surgery really doing what it's supposed to? Because outcomes sometimes were good, but then sometimes they weren't so good. And they started questioning, like, does everyone, just because they show signs of FAI on their image, and then when they go in and they see bony abutment and they go in and influence it, is it actually helping patients? Is it actually required or needed? Because they started to see more and more that morphology, abnormal morphology on folks, was actually normal. And not everyone has pain when they have abnormal morphology. So it made surgeons and the whole healthscape kind of take a pause around that 2013 to 2016 mark. And then 3 massive get-togethers happen amongst healthcare professionals. And so here's this history that I really want you to appreciate, is that there were 3 main consensus statements that have come out, one in 2016, and then 2 in 2019. So I want to review those with you so you kind of have the background. So after this massive influx in surgeries that they thought, that they were the white knight coming in and preventing hip OA from occurring, not necessary. So the first one in 2016 was the Warwick Agreement. This involved 22 panel experts, so a mix of different disciplines, and one patient. So that was really cool. And it was from 9 countries and 5 different specialties. What they said was that, and found, and this is significant, and if you don't know this, you're a little behind, is that there had to be 3 findings for folks to be a candidate for surgery. And those 3 findings, known as the triad of symptoms, were a patient had to have pain. They had to have clinical signs. So when you did an exam, right, you did fader, you had them squat, it calls their symptoms, right? Pain, popping, clicking, deep groin ache. And they had to have imaging. So Warwick said, take a pause. These surgeries are not indicated unless all 3 things, this trifecta, is present. And they also, in that get together, concluded that a lot of folks, abnormal is normal, that a substantial proportion of folks have abnormal morphology and don't have pain or don't have limitation in function. And that is why it was so important to recognize that all 3 had to be on board. Next was the 2019 International Society of Hip Preservation. Yes, that's a mouthful, where 11 physios got together and 8 orthosurgeons to discuss, so what is the best exam for these patients? So we know the triad now. So 3 years later, how do we actually examine and find out if these people, these humans that have some signs of FAI, how do we know that they need to go on to surgery or they'll benefit more from conservative care, from PT? So they came up with that a great exam is the key, that both PTs and orthodocs need to be able to rule out groin and lumbar spine pain, because we can get referral in that is like FAI. So you need to rule out those being present. And then you need to be able to really differentiate between your intra-articular hip versus your extra-articular hip, which is something we go deep dive into in extremity management. But some quick basic is intra-articular. We really want to look at motion restriction. So you're going to look at passive range of motion with overpressure. You're going to do your tests like Faber and Fader. For extra-articular, it's really going to be your manual muscle testing and palpation. So that 2019 AISHA, for short, so we don't have to say it again, concluded it's that great exam that is really the key. And it's not just our PTs that need to champion that forward, but it's also our ortho docs to really know, does this human need to go on to surgery? Or are there some things we can do as PTs? More on that in a bit. And then our other consensus statement that happened in 2019, and this was purely from a radiological perspective. It was called the Lisman Agreement on FAI and how they should do imaging. And so this was made up of 31 radiologists and 9 orthodocs. And they said that they wanted the image to identify chondrolabral defects and needed to detect early or focal OA. That was really the cornerstone, plus a hip evaluation that needed to have symptoms. So they agreed with the Warwick that you have to have symptoms, but they wanted that specifically show up on the image for that to say, ooh, FAI might be a problem. They also recognize in this Lisbon Agreement that complete resolution of symptoms with surgery is not guaranteed. And so this brings us kind of to our problem that still exists, that even though we have consensus on what kind of image and radiological report we should get, even though we have that triad of symptoms where we know they have to have symptoms, they have to have an image, and their exam has to elicit symptoms, we still see over medicalization here. We still see folks, even though it's slowed down from that 2003 to like 2013 time, we still see it happening. And outcomes are very fluctuating. So what do we do? What is the solution if we're still seeing a problem, even though we've had these 3 massive meetings, right, where we have agreement amongst professionals? Well, the solution first is we have to speak the same language, right? You've heard me say the triad of symptoms now at least 4 to 5 times now. If you don't know this, like, you have to know it going forward from this episode on. And your colleagues need to know about it. The ortho docs you need to work at it need to know about it. Your primary care docs, right? Especially if they're the frontline provider, right? They need to know about this triad. You can't see as a primary care doc someone with hip pain and not touch them at all. Just say they have hip pain and go get them an image. You're doing them a disservice, right? And this leads them down a path to over medicalization faster, more healthcare dollars, and without, and obviously I'm biased, that PT first strategy, without giving them the option for that, they often believe that surgery really is the only path. So speak the same language. And this really starts in that diagnosis and exam. So coming back to whatever doc, whether orthos are going to be more experienced in this, right? But our primary care docs aren't, and our radiologists are not going to be. And so if you have the opportunity to have multidisciplinary communications, you need to be on that team to say, well, we need to do an exam, right? We need to look into their chart history, and we really need to gather that subjective to make sure that's a part of it, right? And that's a radiologist's job to actually look at that part too and combine. It's not just look at the image and give a diagnosis. It's to understand the subjective and their history and what they came with, and look at what exam findings are. As a PT, what do we do, right? I think that's probably, so speak the same language as healthcare providers, our orthodox, our radiologists, know the triad of symptoms. And for us, it's doing a great exam, doing a simple yet focused exam that knows how to rule in and rule out intra-articular hip versus extra-articular hip. And I've already mentioned a few, but to review, for intra-articular, right, we're going to want to look at passive range of motion. We're going to want to look at Fader and Faber. The squat is a great screen for that as well. And then for extra-articular, we're going to want to look at palpation all around the hip, anterior, medial, lateral, and posterior hip, in our manual muscle testing of those structures as well. And then we want to look at any movement asymmetries. We see a lot of lumbopelvic control issues in our folks with FAI. And then last but not least, we have to make sure we rule out that the lumbar spine is a contributor or growing pain. The other thing is our minimum PT, 3 months. When we look at our clinical practice guideline, we had a revision in 2023 for non-arthritic joint pain is what they categorize FAI under. It's Enseki et al. Did this in 2023, and they came to the conclusion that at least 3 months of PT trial is really key here. So besides that great focused exam, knowing the triad of symptoms, treat them for 3 months where we're working on local strength, local control of the lumbopelvic unit, that any musculature that is like hyperactive, that we calm that and then get that built up and strong. And the other part of that is there is a 3 to 6 month window where if 3 months isn't helping, they should get a consult with an orthodoc in that 3 to 6 month window, because our CPG also highlights, and this was in 2023, so just last year, that folks tend to do better if they are surgical candidates, if they do it a little earlier, right? So within that 3 to 6 month window, figuring out a plan if that is the way they're going to go, because you know you're going to see them on the other side if they do end up getting surgery. So it's kind of our job to also know that piece, because they see worse outcomes in those that have suffered for like 2+ years of FAI type symptoms, right, where they truly have the triad, versus those that had 2 years or less of symptoms. So consider try for 3 months PT, but that 3 to 6 month window is kind of a window of opportunity for consult. So in summary, imaging-based decisions are not the way, right? We are going to base all decisions as a healthcare profession and as PTs based on subjective symptoms, positive clinical exam signs, and imaging that shows FAI, either CAM, pincer, or some type of mix. A trial of 3 months of PT is always warranted to see if you can calm symptoms and build up robustness in that hip and lumbopelvic unit. If you want to learn more about specific manual therapy and exercise for folks with FAI, come to an extremity management course. We'd love to see you out on the road. Our next opportunities are January 11th and 12th, one in Gretna, Louisiana, and then one with me in Bear, Delaware, the first state that everyone forgets about. Join me there. And then 2 weeks later, I'll be in Aspinwall, which is near Pittsburgh, Pennsylvania. So a lot of East Coasters just start us off. Join me. I will put links to the 2 articles that I was kind of inspired to share this chat with. Have a great rest of your Tuesday, everybody. Cheers.